Dear friends, on behalf of Tamil Nadu Ophthalmic Association, I welcome you all for this wonderful webinar on disability. Actually, the International Day of Disability was celebrated every year in December 3rd of every year from 1992. It was started by United Nations, and the main aim of this day is to uh, support and uplift the self-esteem of persons with disabilities and to improve their life. This is the aim purpose of this World Disability Day. And also every year they will have some theme. This year the theme of this Disability Day is the transformative solutions for inclusive development. There's a role of innovation in creating an accessible and equitable world. There's a theme for this current year. And of course, their disabilities, all of you know very well. This is there are four major types of disability. The foremost is our visual disability, then of course hearing impairment, locomotive, mental retardation, etc. But they given a lot of importance for the visual disability all over the world. And of course, all of you know the team is doing a lot of work academically last 2 years, and every month we are doing some sort of this type of academic activities, and with so many other in our country as well as other international faculties. There's once in a month we have a guest lecture and other webinars and other talk, just it's a master class, something like that, so going on. But of course, this is something is different. Today's webinar is mainly focused on the low visioning, which is a neglected field in the field of ophthalmology. Most of us, we don't know what to do with suppose a patient comes to basic macular degeneration, RP patient, or ARP. There are so many categories which you people know very well. So what to do for that type of patient and how to rehabilitate them and to suppose not possible, what the other options for them to have their to improve their quality of life. That's the main aim of this webinar. And of course, I have to thank our pediatric ophthalmology department, Dr. Fatima and Dr. Meenakshi and Dr. Neelam for coordinating this webinar by so wonderful speakers. And also I have to thank Dick, that our academic chairman, and also the panelists, Dr. Vijayalakshmi, Dr. Lambu, Dr. Meenakshi, Neelam, and Dr. Deepa John, all are very well, they have a lot of knowledge in this field of visual rehabilitation. And the speakers are leaders, so many topics, good topics, with Sabas, and Sagitya, Sandra, Darageshwari, Fatima, Janani, and Singh. So many speakers today. And of course, we have very limited time, but I think it would be very useful for all of us to today's webinar. And of course, I have to mention one of today is a world we are celebrating the Disability Day, but we have lost one of our closest friends, not only friends, we have lost a very good human being. Most of you know Mr. Manohar Padmasri Manohar Devadas, who was chief guest for our Coimbatore conference, and he was closely associated with Sanganethala and other service organizations. He passed away today morning. It's a great loss for the people of especially the disabled, because he was an RP patient. With that, he has done so much of work which Dr. Fatima will read out during his talk in the first one. And also, it's a great loss for all the, because he's such a nice person, and he has done lots of, even without any, this people with disability, he is taking care, not only taking care, means he is supporting so many low vision activities for so many years. And his mother's wife's name, Mahima Devadas. So that's what Mr. Bhagavan Devadas is. With these three words, I once again welcome all of you, and also I have our Arun is there, our incoming Vice President Nirmal is there, and I welcome all of you for this wonderful webinar, and I hand over the mic to Satya Atik. Atik, please. Yeah.
Sir, with your permission, can we request our Vice President and President-elect to say a few words, sir, before
Yeah,
we...
yeah, they are going to, they are going to, yeah. I thought we first okay, yeah, fine, good, yeah. Yeah, Nirmal, Arun. Nirmal, a few words.
Thank you, President. So happy to welcome all of you for this wonderful webinar. And just heard the President saying this webinar is dedicated to Padma Shri Manohar Devadas. We all know how what an inspiring life he led. Just wrote a memorial message to remember him. Whatever the words he spoke as a guest of chief guest in our TNA meeting came to our mind. What a journey he has led, and not only as an artist, but also an inspiring speaker, philanthropist, and educationist. So even disabled people can lead more than life image. So that's what he personified during his 80 plus years of journey. So dedicated to this wonderful person. So I'm sure this webinar will be a eye opener for not only ophthalmologists but also other people. I've shared this webinar details to the doctors as well as the staff, as well as optometrists and low vision aid specialists in our group and community. I've asked them to log on, see how much we can do for these people, and also how much we can learn from these disabled people. So I'm sure, I'm looking forward to hear from all the expert speakers. I'm sure this will be an eye-opener for all of us. Thank you so much. Thanks, President, for organizing this wonderful webinar.
Thank you, Nirmal. Thank you. Our Vice President, Dr. Arun.
Good evening, President Dr. Ramakrishnan. It's a pleasure to catch up with you. It's a wonderful ARC program that has been curated by you. This is a wonderful topic. Low vision aid is extremely important. It's also very poignant that a person who lived his whole life using low vision aid and contributed so much to society is remembered today. It's truly a magnificent personality who lived life to the fullest in spite of having very poor vision, purely depending on low vision aids. It is poignant as well as very, very fitting that this program is there in his memory today. Best wishes to the program. Let us go on with the program, please.
Thank you, sir. Without wasting much time, I'd like to go on with the program. So I want to introduce our moderator for the day, Dr. Fatima Madam. She graduated from Arvind Eye Hospital, Madurai in 2008. And she's been working as a pediatric ophthalmologist at Arvind Eye Hospital, Tirunelveli. She has done her observership at MEEI Infirmary in Vision Rehabilitation Department, and she's also finished her pediatric ophthalmology in Wilmer Eye Institute, Baltimore, and Boston Children's Hospital. Ma'am has contributed and quite a lot in low vision aids, and she's done a lot of work quite a number of talks and publications in peer-reviewed journals. Welcome, Madam. Heartfelt thanks on behalf of TNOA for getting together a wonderful schedule and eagerly looking forward to listening to this session. We've been overloaded with refractive surgery and refractive talks. So this is something which very few has been spoken on, and in remembrance of our great man, great day to have this webinar. Thank you so much, Madam, for organizing this session, and thanks to Meenakshi, Madam, also for putting this session together. Thank you, Madam.
Thank you, Dr. Atik, for that kind introduction. Thank you, TNOA and TNOA President RK sir for organizing such a wonderful webinar. Let me few words about our Manohar Devadas sir. Manohar sir, the artist, writer, and scientist, has been a great friend of Aravind for the past 2.5 decades. Life has been
Madam, your voice
yes,
is cracking.
sir.
If you don't mind, you can turn off your video and talk, Madam.
Is it fine now, sir? Is it fine now?
Yeah.
Better.
Slide mode, slide mode, yeah. Full slide mode.
Full screen. Go to full screen, Fatima. You cut off your video, go full screen.
Yeah. Yeah, is it fine now? My slide.
Screen you can go.
You have to put it on slideshow, ma'am. You have to start as a slideshow. So, okay, go ahead.
Slideshow.
Is it full screen now?
Ma'am, please go ahead, Madam.
I have done it probably. Yeah, okay. Manohar sir, the artist come writer and scientist, has been a great friend of Aravind for the past 2.5 decades.
Your screen is not shared.
Life has been extremely trying. Yeah, am I audible?
You're
Am I
audible.
audible?
Your screen is
Am
not
I audible?
there. Your screen is not there,
I
madam,
am.
please.
Okay.
It's come. Again, it's gone, madam. Can you share your screen, madam?
Yeah. Is it fine?
Please wait, madam. Yeah, now it's fine, madam. Please go ahead. Sorry for the interruption.
Thank you. Manohar sir, the artist come writer and scientist, has been a great friend of Aravind for the past 2.5 decades. Life has been extremely trying for him with its series of challenges. Yet, he and his wife Mahima, with all their physical limitations, stood out as a never-ending source of inspiration and positivity. They refused to be limited by their disability and embraced life cheerfully as it came. They excelled in the art of
Achma, you are there? Hello? Completely.
Poor network.
I think she has poor network. You can go to the next speaker, Atik.
Yeah.
So she can join and then take it forward later on.
You can call the speaker. Who is it? Sabayachi?
Yes, sir. I'm here, sir.
You can talk to her.
would like to introduce Dr. Sabir Sachi.
Yeah.
He was a DNB at Arvind Eye Hospital, Tirunelveli, and now he is attached to Vivekananda Mission Ashram, Vivekananda Mission Ashram, Netra Nirmaya Niketan at Calcutta, Chaitanyapur as a consultant, and he has done his pediatric ophthalmology fellowship, and he has a lot of awards. He has got the GB Memorial Gold Medal from DNB, and then he is won the ET Selvam quiz and the Alargan Iridio academic quiz and all that, and he has he got a travel grant to travel to APAO Taiwan because he won that quiz, and he has almost many publications in national and international journals, and he's a very good speaker. And over to Sabir Sachi.
Thank you so much, madam, for that kind introduction. It feels so nice to see so many familiar faces after such a long time. Yes, I had prepared an introduction, but the thing is, the sad demise of Manohar Devadas really moved me. I still remember as a PG, he had come to our grand rounds, and that was the first time I was exposed to him. It is through his book, Greenwell Years, that I came to learn of Madurai as a living, breathing city, and his illustrations are absolutely amazing. I don't know if everyone gets a chance to read this book or not, but I believe as a postgraduate who has joined Arvind, Greenwell Years is something they should definitely read. Now I will go on to my topic of presentation. Are my slides visible?
Yes, Sabir Sachi.
So I'll start off today's proceedings with an overview on visual impairment, and I have no financial disclosures. So I will first talk about the definition of low vision, then go on to the epidemiology, and finally touch a little bit upon the etiology of low vision. So coming to what is low vision, according to the currently accepted definition by the World Health Organization, low vision has both a medical as well as a functional component. So the definition starts with the visual acuity cutoff, then a visual field cutoff, and finally identifies all those people who would likely benefit from low vision care but are currently classified as being blind. The 11th revision of the International Statistical Classification of Diseases and Related Problems categorizes visual impairment in section 9D90. The skeletal framework of this remains the same as the 10th revision, but there are additional post coordinations by which one can actually specify the laterality for statistical purposes. Now I'll come to the Indian perspective of low vision, and this has a little story to it. So when in 1976, the National Plan for Prevention of Visual Impairment and Control of Blindness was drawn out, there was no actual definition of blindness given. So thereafter, Central Coordination Committee came up with this definition, which stated that a visual acuity of less than 660 and or a visual field of less than 20 degrees comprised blindness. However, a problem arose because this definition was much more stringent than the WHO criteria, and the Indian burden of blindness could no longer be compared to that of other Southeast Asian countries which followed the WHO criteria. Therefore, in 2017, the newly renamed National Program for Control of Blindness and Visual Impairment modified this definition to become at par with the WHO definition, so that such comparisons would be possible. In the Indian context, we have certain other terms which we must understand. There is something called an economic blindness, where the best corrected vision is less than 660. Social blindness, where it is less than 360. Manifest blindness, where it is less than 160. And total blindness, where there is no field in both the eyes. Unfortunately, in India, there is no specific visual impairment cutoff for driving, even after the amendment of 2017 to the Motor Vehicle Act. So when a binocular individual wants to get a driving license, he is supposed to be able to read 65mm numbers from a distance of 25 meters, which roughly corresponds to a visual acuity cutoff value of 612, but this is highly subjective. He should neither be color blind nor be night blind. For monocular individuals, Additional criteria which must be met are a horizontal visual field of 120 degrees and a monocular adaptation period of 6 months. However, no other specific investigations are specifically mentioned in the Motor Vehicle Act. Coming to the epidemiology, I'll discuss the epidemiology exclusively in the Indian perspective, and I will refer to this RAB survey, which was conducted by the All India Institute of Medical Sciences in 31 districts over 2015 to 2019. They found that the overall prevalence of blindness was 1.99%, and the overall prevalence of low vision was 13.76% in individuals aged more than or equal to 50 years. And they demonstrated a definite drop in the prevalence statistic from the 2010 values. However, identification of prevalence of childhood blindness is a completely different issue. So I'll refer to this review article, which actually compiles data from all those studies which have studied prevalence of childhood visual impairment and gave this compiled table. So from this, we understand that the prevalence of blindness in Indian children varies from 0.62 to 2.2 per thousand population, and that of visual impairment varies from 2.05 to 13.6 per thousand population. We conducted a survey of approximately 25,000 school children from rural and urban settings and found that the prevalence of visual impairment was 1.353 per thousand population overall. This is much lower than that reported in literature, because this visual impairment was calculated according to the definition provided by the Rights of Persons with Disabilities Act of 2016, which takes into consideration the best corrected visual acuity and not the presenting visual acuity, which is seen in both NPCB and WHO definitions. So coming to the etiology, I refer back to the RAB survey. Here we can see that untreated cataract and cataract surgical complications still constitute the major bulk of blindness as well as visual impairment in individuals aged more than or equal to 50 years. However, some multidisciplinary causes or multi-speciality causes such as glaucoma, retinal disorders, and non-trachomatous corneal opacities are gradually picking up pace. Moreover, we can see that in individuals aged more than or equal to 50 years, uncorrected refractive errors constitute a major cause of visual impairment. The etiology in children has to be studied separately. So when we go back to this review article, we find that in studies which were conducted between 1990 to 2007, corneal causes were the most important cause of visual impairment in children. In contrast, in studies from 2008 onwards, whole globe abnormalities were the most common anatomical causes of visual impairment. So we conducted a blind school survey and found similar findings. Whole globe anomalies were truly the most common cause of visual impairment, and corneal causes were only found in a minority. So with this, I come to the end of my presentation, and I would like to conclude by saying that blindness control programs are definitely providing optimistic results, but as the prevalence of avoidable and curable blindness gradually declines, the need for multi-speciality and multidisciplinary services will increase to combat more extensive forms of involvement. Thank you so much.
Thank you, Dr. Sabyasachi, for that wonderful presentation. Next, we will go on. Thank you. Next, we will go on to Dr. Tanuja from Joseph Eye Hospital. She is taking care of low vision clinic in Joseph Hospital for more than a decade, and she has a fellowship for vision rehabilitation service in their hospital also. Over to you, madam.
Thank you very much. And thanks to all TNO members who invited me for this talk. It's nice to see many faces, and start my share. I hope everybody can see my.
Yes.
1 minute. Yeah. The topic is entities or disorders causing low vision and their implications. So low vision can be classified according to vision loss or to age, in old age, childhood, and so on forth, according to the disorders and according to the anatomical part affected. The causes of low vision among disorders involving, we can again divide them into those involving the optical media, those involving the posterior pole and macula, and those involving the peripheral retina and visual pathways. And what are these diseases? Peripheral retina and optic nerve, we have primarily diabetes, vascular pathology, retinitis pigmentosa, glaucoma and optic atrophy, and of course some others. I'm just naming the few main ones. Posterior pole and macula, you have macular dystrophies, coloboma, toxoplasmosis, and of course ARMD. And optical media disorders are cataract primarily and refractive errors. Nystagmus and albinism can fall into any of these things, and apart from that, microphthalmus. And of course, your corneal opacities and all that will come in this. So what are the implications of these disorders? So peripheral disorders would cause inability to identify objects, people at the side, unusual head movement, disorientation and mobility. Whereas those with central retinal disorders, you have partial perception of people and objects, an inability to see near and distant objects, and they might have different head posture when in mobility and ear work. These are primary main points that I'm telling you. And those with optical media problem, they have loss of contrast, clarity, and minute details may not be seen, sensitivity to light, inability to concentrate, and of course fatigue. So major causes worldwide are, as seen, cataract, refractive errors, glaucoma. I put all the retinal disorders together because ARMD, of course, it's the primary one. And then we have ROP, but ROP is also separate, and corneal causes like corneal opacities and everything. And of course, others, under others, I would say primarily, I was happy to hear the previous speaker mention it, those with multiple disability. These this special population does have a lot of problems with vision. So what are the conditions? And these are the primary conditions. So I'm showing you the consequences. What are the consequences of these conditions? And that is a person with low vision and cataract, they have problem in doing different tasks, illumination problem, they might need more light, less light, glare. Refractive errors, they have problems seeing objects because of the clarity, lack of clarity and contrast, reading blackboard, doing near work. And of course, you can see that they have a lot of frowning, squinting. And in glaucoma, you will see these people having difficulty in reading, traveling, scanning, tracking. They may bump into objects and people. And corneal causes, the vision is often affected by where the opacity or the lesion is. And glare and photophobia, as we know, is always there. And they have illumination problems. Not necessarily that everybody needs less light. There will be people who might need more light also. And retinal problems, problem with mobility, seeing fine details, especially those with macular disorders, near work is a problem. And some need more illumination, but these people also can have glare. So looking at this, we see that low vision services need to be not addressing visual loss alone, but consequences of vision loss. And I hope I look forward to hearing the other speakers speak more on this and what is the interventions we can give to help our patients overcome the consequences of vision loss. Primarily, we are dealing with consequences of vision loss. Thank you.
Thank you, madam. Despite your personal commitments, thank you for taking part in this webinar and sharing your talk. Thank you very much. Before we move on to the third speaker, let me brief about the panels. We had actually Dr. P. Vijayalakshmi Madam, whom needs no introduction. Madam is the first pediatric ophthalmologist to get trained in the early 1980s. Since then, she headed pediatric ophthalmology in Aravindaya Hospital, Madurai, and she has received Lifetime Achievement Award 3 times. Madam, due to her personal work, she may join a little later. And next we have Dr. Ilango Krishnamurthy. He is the professor and HOD of Velamal Medical College Hospital since November 2016. Formerly, he was a consultant at Aravindaya Hospital, Madurai between 2001 to 2016, where he was instrumental in developing the low vision service at Aravindaya Hospital, Madurai. He has 20 peer-reviewed publications in national journals, and he has received Mahasabde Gold Medal Award from AOS. And he has authored a chapter on low vision aids in textbook of postgraduate ophthalmology by A.K. Gupta. And he is invited by WHO for technical consultation to Rome. Then we have in panel Dr. Deepa John. She is a member of Ophthalmology Society, TNOA and AOS. And she is running pediatric ophthalmology service in CMC Vellore for the past 15 years and a special clinic for children with CVI for more than 10 years and has experience with low vision clinic for more than 8 years. She has guided many dissertation and projects and has many publications to her credit. Then we have Dr. Neelam Pawar. He is my colleague working as a medical consultant in pediatric ophthalmology in Aravind Hospital, Tirunelveli. Also takes care of Vision Rehab Clinic. She has done observership in UCLA and Wilmer Eye Institute, Baltimore. She has many peer-reviewed publications and even in the field of CVI. Let us move on to the third talk by Dr. Sahitya Bhaskaran. Dr. Sahitya Bhaskaran is a consultant in pediatric ophthalmology department in Madurai Aravindaya Hospital. Her area of interest includes functional vision assessment and vision rehabilitation intervention for children with CVI and orientation mobility in pediatric age group. She and her team have worked with children with autism spectrum disorder and developed protocol for functional vision assessment and has developed a Vikas Android-based app for children with CVI. Over to you, Dr. Sahitya, for your presentation.
Thank you so much, ma'am. At the outset, I'd like to thank the organizers for this opportunity. So I'll be talking on assessment of cerebral visual impairment and areas to focus. I'd like to pay homage to Mr. Manohar Devdas today here because we had the privilege to share a few moments with him, and most of our visual rehabilitation center that is there today owes a lot to him. He's always been a very positive person and an inspiration to all of us. So we'll miss him dearly. So over to the talk. The previous speakers had mentioned the causes of vision impairment. And if you look at children and vision impairment before 3 years of age, the major cause of vision impairment in children is CVI. The data that you're seeing right now is the Western data, the University of Kansas data. Whereas if you look at our data also, almost 26% of profound visual impairment in children before 3 years of age owes itself to cerebral visual impairment. So how does the actual assessment differ in these children? When you look at assessment of CVI, it not only depends on age, but also the ability of the child and the developmental status of the child and how many tests are testable in such children. We can't just rely on traditional methods of testing. And to look at a broad overview, you always need to review the medical record to know what systemic features are also affecting these children, namely epilepsy, or are they on some other medications that would make them drowsy. Observation, interview with parents and caretakers, and then the routine standard ocular protocol along with functional vision assessment. So when you observe the child, always make a note of their head posture and how the child behaves. Do they have face turns or compensatory posture? Sometimes they'll have specific visual behaviors like gaze aversion, or they look at light and intense looking at light and small particles. So that will classify children whether they are into the hyper visual acuity zone or hypo zone. Mostly children under spectrum disorders will have this intense gazing to light and all that. Some other group where they have hypoactivity, they might have gaze aversions. Coming to visual acuity testing, like standard testing charts are not useful in many of these children with profound CVI. So look at localization of light. Are they able to just localize if the presence of light or not? Detection acuity, resolution with Leah paddles, stellar acuity cards, so on and so forth. If the child is verbal and is able to read, then we can put them to shapes matching or to standard logmar charting. But one point that is very important to remember is that you cannot compare one chart to an other chart, meaning you cannot compare a Leah paddle visual acuity to a Snellen acuity, and you cannot convert a grading acuity to an optotype acuity as well. So the distance vision assessment, you have Leah symbols, K pictures, etc. But what is important in these children is always look at single visual of optotype acuity. Do not give crowded charts for all children. Even if they are able to read, it is better to look at the single optotype acuity, because crowding or simultanagnosia is very common in these children, and sometimes that might retard the visual acuity. Routinely in children, we don't see doing a near vision, but in these children, near vision becomes very, very important, because that might be a zone from where your rehabilitation starts. And here is a video where they're giving matching cards. So these are Leah matching cards where you can ask the child to match these shapes, and thereby you can also assess the near visual acuity. Near visual acuity is where the education and everything starts. So this is mandatory to be checked in every child. Next, coming to refraction, always make sure a proper refraction is done, and any refractive error needs to be addressed with glasses in these children. No child is ever too disabled to wear glasses, so always prescribe even a smallest refractive error. And another important thing is that do not wear mini aperture lenses. Try to use full aperture lenses so that it will accommodate for your head turn, sometimes nystagmus, and a wider field gives a better acuity in these children. Another thing to look for is accommodation reflex. This is also not routinely done in practice. However, many children with CVI can have hypoaccommodation which goes along, and that might impair near visual acuity. I'll show you this video where this child has HIE sequelae, was actually referred to as saying she had cortical blindness. But if you look at her, she had hypoaccommodation, and with a plus glass, she's able to reach pretty well. This is a simple test which can be done in the clinic. A dynamic retinoscopy would help. And if these children have a lag of accommodation, we have to give them bifocals or plus lenses. Sometimes children with spectrum disorder may have a lead of accommodation which might have to be treated. Always make sure you have the protocol that works for you. This is a protocol that we use at Arvind, but whatever works for you is better, because every time randomly picking and choosing on tests is not going to work. So if you have a working protocol, every person who's going to see will always measure the outcomes that you will need. Next, coming to visual field, you can always see the central visual field. They have a black background and they have a pop-up which is shown. So you can check visual field by this, or you can give a obstacle walking. You can see that this boy is just stepping on the toy and going. So either by obstacle negotiation or by confrontation method, visual fields can be done. For slightly older children, a leg raise test can also be used. Contrast sensitivity, this is also mandated in every child with CVI. So you look at the contrast sensitivity with hiding charts. The importance being face itself is a low contrast stimulus. So if a child has to see, and if the contrast is poor, you will have to alter the environment, you have to alter the reading material, the stimulus choice, and also tell the parent at what distance communication exists. Contrast sensitivity is what will tell you the communication distance for every child. Glare, again, patients with glare tints should be prescribed, and they should be assessed for good visual behavior in outdoor activity. Next, coming to the ocular motility, the saccade and pursuit testing. So this is how saccades are tested, where the ability of the eye to move from one target to another. And pursuit, if you see routinely, how this is smooth pursuit, ability to follow. So this is how a normal person will start reading. When you have a pursuit difficulty, see what happens. So these children will start jumping between letters or jumping between lines, and this will lead on to learning disability later. So here I am showing a child with OMA or oculomotor apraxia where there are head thrusts. So a poor saccade pursuit abnormality can also lead to a learning disability. And with multiple disability, fixation or functional vision assessment becomes important. So fixation to mirror and fixation to smiley face is to look for attention. A poor fixation or less than 4 seconds or 5 seconds of fixation means there is poor attention, and it might be a predictive of spectrum disorders or hyperactivity. So these are Lia puzzles. Lia puzzles, again, this will tell you the ability to understand shapes, orientation, and also the depth perception. This is done for 3-dimensional, 2-dimensional. And one extra thing we do is do it in a busy background. So if there is crowding or something, then the child will not be able to perform. So you can see here that simultaneous agnosia, sometimes if you do color vision charts through Ishihara also, you will see that these children will fail. That is because when there is crowding and simultaneous agnosia, they will miss out on the larger picture and start seeing this individual rounds. So in such cases, you give them all these typoscopes where you reduce the clutter and reduce visual array. You simplify visual array so that these children are able to read. Now, hand-eye coordination testing, you see the mailbox testing. If they don't have orientation, they'll start hitting on the mailbox. So this means there is poor orientation. Next, coming to the size perception. This is to know the concept of big and small. So even if you're going to teach them ascending, descending, or one which is smaller number, which is greater number, then they need to have this perception of big and small where they match rectangles. Emotions, facial emotions, this is being checked to know if the child has awareness to what a facial expression means. Typically in autism spectrum disorders, you have this problem where they don't understand emotions, and this might in turn manifest as secondary or negative social behavior. Visual closure, where a part of a picture is shown and the child has to guess the whole picture. So when this is not there, what happens is, can you read this? Everybody, I'm sure, will be able to read this despite having a wrong spelling. This is because your brain just looks at the starting letter and the ending letter, and then it pulls out from the memory. If visual closure is not there, this does not happen. And then the child has difficulty negotiating socially, also in learning. Visual sequencing. So this is where you have an ability of start and stop. So you start you know where to start and where to stop. So when visual sequencing is defective, a child does not know where to start and where to stop. They start brushing, they keep on brushing, or you ask them to tell 1 to 10, they will keep continuing after 10 also. So even with ADL activities, this might become a problem. So training in visual sequencing also becomes important if the child has such difficulty. So this is what is functional vision assessment. Any problem with any of these visual capacities will cause a vision drop or a drop in their functional vision and the ability to go about their daily life. So functional vision examination becomes mandatory to pick up CVI pretty early and thereby treat it. So the challenge with CVI is that you pick it up early. After that, the intervention becomes possible and the child can have a better quality of life. Thank you very much for the opportunity.
Thank you, Dr. Sahitya, for that enlightening talk. We will continue with Dr. Sandra's CVI talk. Then we will go to a panel's discussion. Dr. Sandra is a medical consultant in pediatric ophthalmology and in charge of vision rehabilitation clinic in Aravind Eye Hospital, Coimbatore. She has done vast outreach to visually impaired patients through USAID program. She has many papers and done presentations in national and international conferences. Over to you, Dr. Sandra.
Thank you very much, Dr. Fatima. Am I audible? And my slides visible? Yeah.
Yes.
So, thank you, Dr. Sahitya, for the wonderful presentation. So it makes my work kind of easier. So I'll be giving a few case examples as to how early intervention is very essential and key in the treatment of CVI. So let us start with a story. This is 8-month-old Mohammed who was born preterm. He presented that he was born at 32 weeks with a 2.4 kilo birth weight. He had disc pallor, poor visual milestones, global developmental delay, and on MRI, he had periventricular leukomalacia. This is a video taken when one of his initial visits. You can see that his mom is trying to get his attention to a lighted toy, and he has poor visual behavior even to the light fixation. So at that point of time, we had given +5 glasses. The high addition glasses are to help in magnification, especially in children with low vision. So usually we do not correct hyperopia in children, but in kids with low vision or CVI, correcting hyperopia would help in magnification, and also in kids who have poor accommodation. So we had recommended mirror play also. As you can see in this video, he is enjoying looking at himself in the mirror. To show bright, shiny colored objects one at a time, to start with simple words, and physiotherapy for the motor milestones. 2 months later, the child showed some improvement and he was able to recognize his siblings and other family members. And again, after 2 more months, he could see the 25% contrast chart and the hiding Heidi, and he was able to fix well, but though with a field preference. So the challenges in the treatment of CVI is that the problem is quite complicated and diffuse brain pathology and variable brain injury. So the presentation in each kid with even the similar problem is quite different. And they may have comorbidities, including impaired cognitive function, speech and motor abilities. And in higher functioning CVI and in kids with multiple disability, it may be difficult to characterize, and hard to predict the functional outcome or recovery, and hard to design an individualized intervention. But we do know that early recognition, early initiation of therapy, and continuum of care are very important to proper management. And Mohammed was seen by us in the beginning of 2020, which was the year of lockdown. So we were looking at telemedicine, whether it could be an interim solution to provide timely services and easier follow-ups. So we followed a hybrid care system started from that year because of the lockdown. And we listed the children in our clinic and the evaluation, as Sahitya has already detailed. And we formed an individualized plan for each child. And we asked the parents for the feasibility of online consults for the follow-up visits. So this was quite successful. So we didn't have to call them to the clinic assessments very frequently. And in the follow-ups was usually every 2 or 3 months following the initial evaluation. And in the meantime, we sent a questionnaire to the parents to assess the functional vision and the CVI characteristics, and also had some questions to show the caregiver's understanding of the child's condition, satisfaction with the program, and any recommendations. And the answered questionnaire and the videos demonstrating the child's visual function were sent to us in advance. And then we arranged a consultation based on the Zoom platform, which we taught to the parents how to use. And we also assessed the performance of the kids in their home environment. And in these assessments, we try to include the child's pediatrician, occupational therapist to get a holistic view of the child's condition and also to offer recommendations. So this was the questionnaires of Mohammed. We had regularly followed him. And you can see this quite in the recent past, around 2 to 3 months ago. And you can see him able to feed himself. And this is Mohammed enjoying a playing session with his child. So this is all over a period of 1 year. The child was not able to fixate on light in the initial visits, can now feed himself, play with the siblings, and enjoy playing in a playpen all by himself. So recently we had seen him last week. And this is Ms. Jeeva, who is a visiting therapist trained by Dr. Namita Jacob. And she had assessed him, and the recommendations given in the final visit were to avoid clutter, show one object at a time, high contrast background to present the materials. As you can see how she is presenting it on a black background, to encourage to move for a purpose, whether it's for a food or toy or to meet with people, to teach the name of objects when he explores it, to talk in simple sentences, good lighting, avoid glare and shadow. So we really see that he has come a long way from where he was 2 years ago. This is Vikshana. Initially, we saw her at the age of 8 months. Her mom had hypothyroidism in pregnancy, and she was born term with full birth weight of around 3.1. And very sadly, on the 6th day of life, her RBS dropped to 30. and she had developed seizures due to hypoglycemia. She was treated as an inpatient in a tertiary hospital for 10 days. But because of this hypoglycemic issue, she had a brain injury in the parieto-occipital region, which was quite extensive, and had cystic encephalomalacia, and she has developed seizure disorder. And she has baxi-pallor in both discs. And though she was able to accommodate, we prescribed a plus 3.5 glasses. And at that point of time, she could though reach out to toys, and but the visual behavior was not appropriate for age. And also she had developed a exotropia. So again, this is Suvikshana being followed up regularly. And this is Suvikshana now. As you can see, she's able to play, she's able to fix and follow and enjoy playing with the sound making toy, and able to respond to her mom. And this is her mom working at home with mobility. As you can see, because of low vision, she also has a pattern background on the floor to follow with a texture. So she's walking well, and her exotropia has also reduced significantly. Though she has seizures are well under control, but she's coming to us for therapy. So how this early intervention works, because even though some of the brain is damaged, as the attention systems mature, you should remember that this is at a plastic period of the life, especially from birth to 3 is very important. So as we give the early intervention, there are alternative pathways which can develop, and that can result in dramatic improvement in the use of vision. And children who begin by giving even inconsistent response to light can progress to use vision to support mobility and even reading. But we should always remember to train vision in the context of key areas of normal development. So this is baby Haim Syed, whom we saw at 8 months. Mom had pregnancy-induced hypertension. He had a lot of issues at birth with an imperforate anus, was operated on the 2nd day. He also had a congenital heart disease and delayed milestones. And he now at present he can walk with support, speaks in bisyllables, follows orders, reaches out to toys. Though thankfully his MRI brain was normal. He had some seizures, and but anti-epileptics has been stopped now. He also has a genetic issue with the loss of chromosome 18 cytogene, and he has an exotropia of 35 to 40 degrees, which we plan to correct once we get a GA fitness. And this is Mohammed now. As you can see with the regular intervention, this is an old video shared by the mom from home where you can see him playing with the toys. He accepts the glass very well. And you can see now, around 2 weeks back, he had come to us for review. He's even able to stack the toys. He has gained good mobility. He can pull himself up. He can recognize colors. So he's around 2 years old now. He can look and play with the case effective toys. These are the recommendations given at the current visit. Use high table to sit and play, to encourage, to keep attention, use gestures to communicate, etc. So you can see here, can follow simple instructions, and he can stack the toys very well. So he also has shown a significant improvement starting therapy at the age of 8 months. So the general principles of intervention is to prepare the child, good posture, descriptive language, enhance facial contrast, toys that match the threshold of vision, simple background, and multisensory stimulation. So the interventions are always suggested based upon at the phase of CVI at which we see the child. For kids who are in the phase 1 where they can have poor fixation, we advise to show single bright colored toys in a darker area, supplement with tactile or sound. Phase 2 or 3, mirror play, sibling play, start with mobility training. And then if they are non-verbal, they can have gaze pointing. And do not have clutter, which is very important in the treatment of CVI. Their rooms, their books, and even their bed, it's better to have a plain background. So this is Neona Rajesh, born full term, and she had intracranial hemorrhage and thrombocytopenia at birth due to some reason which is not clear. Birth weight was less, and seizure disorder treated with anti-epileptic medication. This mom using the glass at home and getting the attention to a smiley, and she has a delayed latency on BEP and abnormalities in EEG. At present, though she's improving, she's using a plus 2.5 glasses. This is a recent intervention you can see where she's the recommendations are to use the contrast and clear background to present material, not to give continuous instructions, wait for the child to give a response, Use two choices, choice making to say yes or no with the head nodding. Encourage to scan all the other options before picking up toys. To introduce vegetables and fruits as a whole and make her sit and observe as a family. Take her to the washing area, watering plants. Encourage her to look at distance. This is a nice video shared by the family from home where you can see the sibling encouraging the child, feeding the child, and that promotes a lot of bonding with the family. So even she's on the way to improvement, though she still has some progress yet to make. Dishant, 1 year, 9-month-old, mom had hypothyroidism and he was born okay, but he had chikungunya encephalitis on the 6th day of life, and there was a delay in motor milestones. And the encephalitis resulted in post-encephalitis sequelae with significant atrophy of the frontal parenchyma and hypomyelination. Yes, disc pallor was advised plus glasses. This is the video from home where you can see he's playing with a mom with a colored toy. These are all the recommendations given at various points of time. You can see again mom showing a lighted smiley and the parents, these are parents who really didn't know how to use the smartphone or Zoom, but they are really able to take the advice and learned things quite well. And they were, this is how we were in touch with them throughout the lockdown period. In CV and literacy, again, there are a lot of material available. And here in these pictures, you can see the kids who are in the phase 2 or phase 3 being guided towards pre-literacy because like you can see the coloring, simple things which can be done at home, like filling the coins in a box, like simple play, and the therapist working with the kid, matching and learning to put an A. All these are being done at home or with the therapist and shared with us. And always try to infuse the interventions in the child's daily routine with some outdoor play. Child being able to feed himself, and that's a sibling play. And here you can see the therapist guiding the child towards recognizing colors. So you can see the child is able to recognize colors very well now. So, and also is able to play the puzzles. Simple activities like putting the rice in a cup, and this is again the therapist who has shared the video with us with mobility training somewhere in Kerala. So this way we are able to communicate with the other specialists as well. And the additional benefits discovered in telescreening was that it's convenient and cost effective. Children are examined in the familiar home environment. We can connect with multiple specialists and give our feedback. It definitely reduces the number of in-person visits, and it reduces the economic burden on the family. And also it serves as a platform for training. And we have our mentor, Dr. Linda, connecting with us every 2 weeks or so, giving her points. And also trainees from around the world join with us on our Zoom meetings. And treating the kids with CVI is always a team approach. Only then it will be successful. Always remember the red flags. If the child is born with any perinatal issues, we have to keep CVI in mind and screen very fast. So I like to acknowledge my team at Pediatric Ophthalmology AEH Coimbatore, Dr. Linda for her continued support, Dr. Namita ma'am for her inputs, Ms. Jeeva Puttusamy, trained by Namita, who's been a visiting therapist with us, and this is a team effort. Thank you very much.
Thank you, Dr. Sandra, for that wonderful presentation with the beautiful illustration from the patient side. Very nice to go through the milestones. May I request the panel members for their expert comments? Pediatric ophthalmologist, Dr. Deepa Jan and Dr. Neelam.
Yeah, Dr. Sandra, thank you for sharing your all experiences. Even during Corona time, so many people have published it as an opportunistic thing that telehealth, visual rehabilitation has really made a successful approach, even though sitting at a distance, but most of the people, they have found that this telehealth visual rehabilitation has really proved better. Maybe the patients and parents are more comfortable, and because if they're coming to visit, maybe because of financial or some other reason, bringing a child is difficult, but with this type of telehealth, most of the low vision children are benefited. Just two questions from you, Dr. Sandra. Do you see any correlation between the extent of CVI and changes in MRI? Because so many times we see MRI changes will be so much, but child will not be so much, vision deficit will not be there. And sometimes with minimal changes also, uh, we will see that the vision impairment is gross. So you have done so many studies on CVI, so whether you have correlated that functional changes in MRI, whether it corresponds to the severity of CVI?
I think it's more to do with the area of the brain which is affected and what problem is there that we see in the child, like whether it's the frontal association areas or the occipital region which is more affected. So based on what type of pathology you see in the MRI, the area of the brain that is affected can lead to the subtle changes that we see in the child later on, like they may have a frontal lobe issue or they may have a parieto-temporal issue more. But with regard to comparing the depth of issues in the parietal lobe or occipital lobe itself, I think that, as you said, doesn't have a direct correlation. It may be variable in the presentation. Sometimes only thing is if the optic disc is very pale, that indicates a very significant optic with anterograde disc pallor also, and that may result in an added poor vision with the child, so it may not be so the visual improvement may not be that much. So if there is significant disc pallor, then the prognosis is little less as compared to a child who would have a normal disc on fundus evaluation. Otherwise, the child, kind of like Dr. Dutton, the way he explains to correlate, I think it would need a lot more studies on these children with over a long period of time, as probably he's talking about like 30 or 40 years of experience following the same kids over and seeing exactly what are the pathways which are defective. That would need a lot more study in depth.
Yeah, which area is affected, whether child, even if it is standing, how he is going, whether he's writing or also whether everything is going in line. Yeah, that is true. And what is your experience in like what type of strabismus you see more commonly? Either because we see more whether exotropia or esotropia, which type of strabismus?
It's mostly exotropias. I see more of exotropias in children with CVI.
Yeah. Thank you, Chandra.
And also they say it's better to correct the strabismus once there is a fitness for general anesthesia. Dr. Linda believes that correcting the strabismus would help in developing the motor milestones if they are delayed, coordination and other things.
Yeah. Sometimes in esotropia, we are confused because for normally we will operate normal our congenital infantile esotropia at 1.5. But with CVI child with so many disabilities, we are always in dilemma whether to treat, whether we will overcorrect it or whether we'll undercorrect it. So somehow it get delayed in infantile esotropia and CVI.
I think we are more worried about the anesthesia risk in these children in a year. Rather than the angle measurement as such, because most of it will be large angles. So the measurement and we are aiming after surgery is just to see the improvement. Like if there is a esotropia, whether the temporal field is better when you analyze with any fixation target or a ball or anything. So if there is a severe esotropia, once you correct it, then their field improves. So that may help in better mobility. Similarly, exotropia, again, if it is very poorly controlled, their motor abilities like catching a ball and all may be defective. So it's better to correct that, provided the kid is fit for surgery.
Yeah. And one more important, in one case you mentioned about hypoglycemia. I think this is one of the cause which is mostly underlooked and not reported. Only when children come to us and when we see the file and everything, somewhere it will be written like hypoglycemia, one episode. So many cases are like underreported. So many
I would like to make an advocacy on this platform because it is so sad to see that hypoglycemia itself can cause such severe presentations. We are seeing many children who are born at term, and due to some reason they are not fed well on the first day or second day. Maybe the mom has not learned the correct technique, has not been taught, and has had severe hypoglycemia resulting in irreversible brain pathology. So I think even recently, 2 weeks back, we had an RFP day, we had a meeting with the pediatrician. So at every opportunity, I try to tell them that if there is anything suspicious, it's better to get an RBS done. And once before discharge, make sure that the parents and the family know about the feeding technique and other things. So probably we should take it forward from TNO side also.
Yeah, because so many times parents will keep on investigating, doctors will keep on investigating different enzyme panel tests, gene panel tests. They will not reach to a conclusion, and somewhere it will be just a hypoglycemia of one day responsible for this CVI.
Thanks, Sandra, for bringing that about that hypoglycemia. Like ROP about oxygen, we should bring this also into the mainstream. All pediatricians should know about. I mean, at least know that this is happening.
Yeah, Dr. Sahathya and Dr. Sandra has covered CVI in great detail. Thank you very much. Occasionally, we see that children with development delay and visual impairment, all of them may not have the features of CVI. Some of them fall into other categories. So when you assess them in a systematic way, some of them fall into some syndromic states where CVI is not seen. However, the rehabilitation strategy remains the same. Also, like they mentioned, Dr. Neelam mentioned, now we see some of the school-going children with good vision or almost good vision with learning disabilities, and when we assess them, we see that they have these dorsal and mental stream features which fall into the CVI category, which need all this optical and non-optical low vision devices. That is when the low vision comes into the picture in the school-going children with the CVI, while we have covered in detail the early rehabilitation part. Thank you very much. I have one question to you, Dr. Deepa. Yeah. How often do you do VEP in CVI children? VEP, we don't do very often in CVI children because the outcome of VEP findings are not correlating to what we are seeing. Like Dr. Sandra mentioned, it is usually the optic nerve assessment or clinically itself will let you know that whether the visual outcome is going to be good or not. We had done a small retrospective study which said that the optic nerve pathology, vision at the presentation, and the age at the rehabilitation, when we start the rehabilitation, these are the factors which actually contribute to the visual prognosis, not the VEP. So we don't routinely do VEP in CMC for children with CVI. Okay, thank you. Next, we will move on to, we have a professor joined here from AIMS. He wants to get his talk earlier, so we will advance his talk. Dr. Suraj Singh Senjam. He is professor working currently in community ophthalmology, RP Center, AIMS, New Delhi. He has done his post-graduation in community medicine from PGIMER, Chandigarh, and completed master's degree in public health for eye care from International Center for Eye Health, London. He is working in assistive technology for visual impairment and low vision rehabilitation in Dr. Rajendra Prasad Center for Ophthalmic Sciences. He has published more than 75 research papers, including papers related to assistive technology in national and international peer-reviewed indexed journals. He is the editor of the book entitled An Introduction of Assistive Technology and contributed many chapters in Elsevier publisher in low vision and assistive technology. Currently, he is working on improving assistive technology with WHO CRO. He has led the Rapid Assistive Technology Assessment India survey supported by the WHO Geneva. He is one of the key investigators for the National Blindness Survey in 30 districts of India and the National Trachoma Survey India supported by the Ministry of Health, Government of India. Over to you, Dr. Suraj. Thank you for accepting the invitation.
Okay, thank you, Dr. Fatima, for a kind introduction. So my apology to the panelists and other speakers, because my son is not feeling well. Today he could not go to school. So he's having fever and vomiting and also headache. So that's why I request to the organizer to kindly allow me to present earlier. So let me share my slides. I think I'm audible.
Yes, yes.
Yes, sir. Yes, Dr. Singh.
Okay,
Yes.
okay, nice, sir. So let me go to slide. So at the outset, I must thank to Tamil Nadu Ophthalmic Associations for this wonderful opportunity to talk on this vocational rehabilitations. That is, we usually consider as one of the very important parts as far as we talk about this vision rehabilitation is concerned, and also low vision is concerned. So this topic is, most of the time is being a working under the Ministry of Health and Family Welfare. So we usually ignore, because why we ignore? Because this area comes under the purview of Ministry of Social Justice and Empowerment. So there are two ministerial divisions in the Ministry of Council. The one is the Ministry of Health, another one is the Ministry of Social Justice and Empowerment. So the Ministry of Social Justice and Empowerment directly look after this welfare of those disability at the ground levels in terms of their livelihood. That's why we hardly, come across this term during our MBBS course, during our MD course. Even in my MD course, we just one small chapter about rehabilitation or those medical, social, and vocational and psychological. We don't have much about this topic, but over time, the needs comes, demand comes, then we started exploring this topic, what is all about. So I feel this topic is very, very important. So let me go through it. Let me start with the outlines. So first, we should know what is vocational rehabilitation. And the second, I will talk about the employment options among the blind and low vision person, which is very, very important. And the role of vocational rehabilitation officer and counselor in the centers. And what do we do here in the RT Center as a part of the vocational rehabilitation using an inclusive model. And then I will be talking in 3 different case scenarios. So in the subsequent slides, and a little bit about this National Handicap Finance Development Corporation, the government of India, which is very, very important as far as disability, person with visual disability is concerned. Now let's move on to some facts. So it's very unfortunate in the country that we do not have data on how many person with visually disabled employed. So this is data from the United States published in Journal of Blindness, Innovation and Research in 2015. So the employment rate among the person with legally blind and visual disability is 37%. I must say in India, so we can easily head count. So even AIMS, we don't have any person, any staff with visual disability working in AIMS. That means, so across India, we have 1.3, 1.4 billion population, so we can head count rather than representing in terms of percentage. So that's why this topic is, I consider, is very, very critical, important. At the same time, the report says that the Journal of Blindness and Innovation Research, that there's a huge gap in terms of employment. Okay, that's male and females. Male is much, much higher, even in the high income country compared to the female in terms of employment is concerned. And now that education attainment is directly associated with the better employment. This is universally true. And I must give some little bit emphasis in terms of Braille and working cane, using cane. For individual with visual disability who read Braille, okay, who knows Braille, at the same time use white cane, working cane, and they are more likely to be an employee compared to the person who doesn't know the Braille and doesn't use the cane. Okay, and then the 2 important factors that affects the employment directly, that is what? That is education and rehabilitation training. These 2 important, for us, it's very, very important to focus right from the, the clinical service, the low vision assessment, for example, CVI, we talk about a CVI. Okay, so right from the beginning, we should focus about education, because eventually how to support those people in terms of living independently. That is employment, earning money, livelihoods. So education is very, very important. At the same time, the vocational rehabilitation. Now coming to the vocational rehabilitation, what is all about? This is a continuous and coordinated process, okay, of rehabilitation activities. So under this, we have the vocational counseling, guidance, vocational assessment, training, and selective placement. This is very, very important. This is some kind of, you can consider is a formula. Okay, so this is based on the international level organization definition. The first is vocational counseling, guidance, assessment, training, and selective placement designed to enable to to enable a disabled person to secure and retain suitable employment. Okay, so this is one of the, that there may be other definitions, but I consider this is one of the very good definition. And at the same time, so whatever, the origin, the nature of disability, the type of disability, so the vocational rehabilitation is a mandate we should consider for all kind of disability. And at the same time, we usually provide a medical rehabilitation in the hospital. Okay, so the medical rehabilitation, the staff, the doctors, the optometrists, the pediatricians, the ophthalmic pediatricians, and they should always think about the vocational rehabilitation while providing a medical rehabilitation. So always link, is always better to have some link. So not only the confined to the medical rehabilitations, but those even children with visual disability. And this RCI, I think all of you know that Rehabilitation Council of India. So there are certified vocational rehabilitation officer and counselors. So this slide is very, very important in terms of as far as employment is concerned. First, the employment in the rural, for the rural livelihoods, employment in urban livelihood, and shelter employment and self-employment. So there are 4 different categories that we can consider in terms of job and employment is concerned. So coming to the rural employments, rural livelihoods, though we have a farm base, okay, the farm base, for example, the agricultural, farms and non-farm, so animal husbandry. Okay, so these are some of the options on some of the options of jobs. There are some, employments that we can consider in terms of as far as rural livelihood is concerned. Okay, and then coming to the urban, urban we can divide into formal sector and the informal sector. In the formal sector, we all know that there are government provides some kind of reservation for those people with the disabilities. For example, person with visual disability, the reservation is 1%. At the same time, in the private sector, private NGO and other or civil-based organizations, okay, there are formal sectors. Those persons with visual disability, they can have an employee, they can get job over there. At the same time, informal sector in the urban setup. So these are some of the opportunities that a person with visual disability can work. At the same time, they can think of livelihoods. This is all about urban. Okay, so it's very common thing is shop. Okay, and refreshment of box making. This is in here in Delhi. We usually a total blind persons. Okay, so like refreshment box. Okay, making refreshment box. Okay, and then massage therapy. These are some of the very common that we usually advice to the person with visual disability who is cross the middle age. Okay. And shelter employment is very, very important. A severe and multiple disability or a disability who cannot work, who cannot go regularly, then there has to be some kind of shelter. Okay, so here in Delhi also it's very common. For example, in Blind Relief Association and AICB, they have a shelter employment. So they provide, at the same time, they train, they provide all shelter also. And this self-employment. So this is very important as far as, the last slide that I'm going to talk, the self-employments, the music trainers, sewing, embroidery, there's some of the, opportunities and then that for a livelihood that can be considered while we provide the vocational rehabilitation for the person with visual disability. A quick view of this, in the public sector, in the government sector, because this is all about, we work in the eye care sectors. I want to mention it, as you know that the 1% job reservations. And, if someone is not able to type, the government, as per the government rules, okay, someone is not able to type, okay, after holding a job, so they can, the person can exempt from the typing qualification, okay, typing, okay, he can be, engaged to other job. And there are 10 years of relaxation in terms of appointment and the clerical and subordinates. And this is very important. 2 days ago, one IS officer, he came. Okay, so in Supreme Court in 1993, the blind eligible candidate can compete. Okay, write a civil service examination. The Pune IS officer, he came and then he talked about this, that opportunities and say what are the, devices, and you want to know what are the advanced high-end devices available nowadays, to be able to use by a person with complete blind. So the IS officer, he suffered from the retinitis pigmentosa. He's a total blind person. So, this is, we can encourage, to the person with visual disability. And this exam from the application examination fees and Ministry of Petroleum and Natural Gas, and they have reserved for 5% with all this person with disability. Okay. So this is in the vocational rehabilitation center. So you have the officers, the counselors, that some of the activities that we can think of. One, I'm not going in detail. This okay. So the first, I will just talk it. A vocational counselor, yeah, officers, he should know it, the disabled persons in terms of their personal, social, family, educational background, economic, and other things. And similarly, he is also able to assess the physical efficiencies. These are some of the important key area that person with the vocational counselor, yeah, officer, he should be able to know, I mean, assess from the clients. Okay, so this is in our context. Okay, so in RP center, so we, since it is a hospital, okay, it's not like a vocational training center. It is an eye hospital. So, but the patient every day we register around 15 to 16 patient, low vision as well as blind. So how to provide this vocational rehabilitation to those patients who visit our clinics? So that's why. So we design a model that is called it the clinical social model. This model I have developed. In this model, so we did mapping, mapping of those NGOs, those existing NGOs working in Delhi and the National Capital Region. So there are so many vocational training centers, so many schools for the blind, and so many other, computer trainers, okay, training centers. So there are so many organizations, and then luckily we're able to map around 85 NGOs, yeah, civil-based organizations, blind schools in Delhi, as well as a National Capital Region. So this model we use it. This is the eye care RP center. Initially, we sensitize the patient refer from the OPD from different units, and then refer to the vision rehabilitation. In the vision rehabilitation, we sensitize the patients. Okay, and at the same time, we contact those NGOs according to the person needs, according to the person with visual disability needs. Suppose someone needs, okay, I want to do a computer training. I want to learn how to prepare a meal. So we contact those NGOs, and then we refer to those NGOs. These are simple, some of the examples. This is the this is the Blind Relief Association. Okay, so, and at the same time, the NGO also refer to our clinic to get examined for disability certification, for so many other, things. So this is the three scenario that I categorize it. Okay, so the first is vocational rehabilitation for those who are seeking for jobs. Okay, because in the clinic you'll find somebody is seeking for job. Okay, for that you have to provide a vocational rehabilitation. And the second one is someone is already working, okay, on job. Okay, and suppose school teachers, and then he became blind in the mid-age. Okay, then in that case, what sort of vocational rehabilitation to be provided? Okay, and the third is vocational rehabilitation for an employee adult. Very common here also. So a person who doesn't know anything about this vocational rehabilitation, okay, he is not holding any job, any employment, and he visits from the remote area because of some other, maybe some accident, maybe some other encephalopathy, some like a tuberculosis, meningitis. There's so many health problems. So they also visit here. So this is just example I'm giving. So three scenario. So vocational rehabilitation for job seekers, vocational rehabilitation for on-job persons, these teachers, example I'm just giving, and vocational rehabilitation for unemployed adults. Okay, this is the examples. So let us quickly go through one by one. This is vocational rehabilitation. As I said, remember, this is the a formula kind of thing. So the goal is to enable a person with disability to secure or retain his or her employments. So there are four important things. While we talk about the vocational rehabilitation. That is a counseling and guidance. Very, very important. Many times they don't know, okay, what are the available options. At the same time, the assessment also very important, because somebody might have some knowledge about it. So the counselor, the officers, he has to assess abilities, aptitude, physical capacity. There are some of the parameters he can assess, okay, and then he can explore it. Okay, the best suitable job for that particular person or for that particular client. At the same time, vocational training, very, very important. Vocational training also, because the person wants assess, then provide appropriate training, suitable one, or as per the choice of the client. Okay, and selective placement, ये बहुत जरूरी है, because sometimes a person who is already on job, sometimes the person need to change his job to other suitable one. This is just example. Just 2 days ago, I named patient Nanda Kishore. Okay, And 22 years old male from Bihar, road and cone dystrophy. This is a best characteristic BCBA and Bachelor of Commerce. And he said, sir, I want to learn how to do a computer because I want to go for computer related job. Because nowadays, he said, so many digital planet, digital literacy, digital India talking about. So I want to know, I want to learn the computer. So this is in our clinic. So we have a JAWS, we have a Zoom magnifier. Okay, so the WHO support us. They provide all the devices, equipment. So we train this students, this person. Okay, and this is for a job seeker that I said the person is seeking for a job, and this is the on job. This is another example from this person is 47 years old from Nainital, Uttarakhand. Okay, glaucoma and glaucoma optic atrophy, one eye finger counting close to face, and he's a school teacher. He is so fear that, sir, don't want to lose my job, so I want to continue to do this job. So for teachers, so the topmost is reading. Okay, so reading is very, very important. Writing, of course, it will be a challenge for them. So for reading, the suitable, what are the device that you can use for the reading purpose? What are the accessible apps available? What are the other, audiobooks? So you have to, accordingly, the person needs, the person capability, the person abilities, you have to decide. And it's like this person, we said for writing, so we can't do anything, but you have to use a computer screen reader. There's NVIDIA as well. Then person said, no, I don't have any capacity that, I don't have the ability, so I cannot use it. So that's why the counselor, the vocational counselor or officer, he has to decide it. Okay. And for writing, we said, okay, so if you want to do some writing activities, or you can take a help of the sighted person. You just pronounce it or dictate, and the one sighted person can write it, what you want to know. And this is teacher, this I have already highlights of the writing with the help of a sighted person. And this is for unemployment. As I said, this is, as of 55 years, maybe 40 years, the patient might come to you mid-year blind, mid-year visual impairment. So these are some of the things: vocational counseling, guidance, vocational assessment, training, selective placement, and at the same time, refresher courses are very important. The last line is very important. Once you think of, okay, this person should go to this place, this person should go to this organization, this private organization. So sometimes consulting with the employers is very, very important. Okay, this is quite for him or is quite new. Okay, so consulting with the employer. Okay, and at the same time, workstation motivation also might be important for them. And this is the last slide. As I said, please do remember, it's a National Handicap Finance and Development Corporation. This is under the Ministry of Social Justice and Empowerment. Under this ministry, there's a department called Department of Empowerment of Person with Disability. Okay, if anybody, a person with visual disability wants to apply for a loan, needs some kind of financial support, and they have to download and fill up the form and submit it. And the state will have a different, under this will be, because this one is the central ministry in the state, there will be some, functionary for that. There's some scheme coming up. Okay, I'm not going to detail. And this is a vocational rehabilitation training center in Delhi. So these are some of them. So we frequently contact. So we refer a patient to this client, to this centers for vocational rehabilitation. Thank you. Thank you so much.
Thank you very much, Dr. Suraj Singh, for that comprehensive, enlightening talk, and including all the government's amendments and benefits. And also thank you for attending despite your son's health issue. Our best wishes for him to recover soon. And to the panel, Ilango sir, do you have any comments?
Yeah, the clinic.
Ilango, how are you?
Yeah, I am fine. And the clinico-social model proposed by Dr. Suraj is, one of the his article in IGVA was really good. This is where the low vision clinics actually goes to the community. Actually, the vision rehabilitation should happen at the community level, because that is where it helps persons with visually disabled at a broader perspective. I think that model, Suraj, you have to take it in a wider area. I don't know how this will be implemented. Probably if the government is also gets involved, I think that will have a very good say. And we also had a discussion on the GST of the low vision aids. Now it is around 12%. I think probably if it comes to 5%, the cost of the low vision aids also will be coming down. I think Suraj is working on that. Thank you.
Thank you.
Thank you, sir. Then next we will move on to Ms. Tara Kesari. She has completed her diploma in optometry from RIOGOH in the year 2004. She has completed her fellowship in binocular vision and vision therapy from Sankara Nethralaya Academy. She is currently working as a senior optometrist at Pediatric Ophthalmology Department and Low Vision Care in Sankara Nethralaya, with work experience of around 19 years in the various field of optometry, enclosing binocular vision and neuro-optometry department. Over to you, Ms. Dara.
Thank you, ma'am. Am I audible?
Yeah, your audible, slides are visible.
So, good evening, one and all present here. So today I'm going to talk about the optical aid, whom to give what. So I would like to start my presentation with a small quote. We can only see a short distance ahead, but we can see plenty there that needs to be done. What is the goals of low vision care? Restoring function by enhancing impaired vision, teaching strategies to compensate for impaired vision, assessing full range of education, rehabilitation, and support and services. Then we'll move on to low vision evaluation. Like we need to ask a detailed history taking, vision assessment, refraction, and confrontation to assess field of vision. How will you start low vision evaluation? First, we need to know the current visual need of the patient, set a visual goal. Whether the goal can be achieved by low vision devices, yes, you need to prescribe LVD. If no, we need to modify the goal and prepare the patient for a possible visual status. Fine. How does we examine a set a goal? First, list the task and see which is the priority in that task. Consider target acuity levels and mode of the management. Okay, we'll move on to the prescribing aspects. When to prescribe and what to prescribe and how to prescribe. Yes, before prescribing, we need to know the visual need of the patient and magnification and the ocular condition. Okay. Apart from that, we need to consider the other factors also. The number one, age of the patient, importance of the devices, handling of the devices, economic background, and the social factor too. Okay, so first identifying the visual need, whether it's for a distance, for an intermediate, for near, or for the mobility purpose. Okay, we'll move on to the ocular condition. Yes, low vision is broadly classified as a overall blur vision, central field loss, and peripheral field loss. We'll move on to prescribing optical devices. The optical devices are available for both distance and near. Before moving on to the prescription, we need to know the optics of the magnifier. If the patient has a low vision, they will not able to recognize the smaller objects and the far off targets. When the target is magnified, the images will cover the more retinal areas. What are the types of magnification? It's a relative size magnification, approach magnification, and transverse magnification, and the angular magnification. What is the relative size magnification? It's nothing but a increasing size of the object. What is approach magnification? It's nothing but a decreasing the viewing distance. Okay, so fine. How do we calculate the power for a distance? We have a formula, the current visual acuity divided by the required visual acuity. We get the power of the distance magnification. Similarly, for near, current visual acuity divided by the target visual acuity into 100 by working distance. But usually the target visual acuity will be N4. That means 2 lines smaller than the required visual acuity. So these are the required visual acuities. For a person who wants to recognize a face within a 3 meter, he requires a minimum of 6 by 24 vision. To read a newspaper, he requires an N8 font size. To identify currencies, N6 visual acuity, and for a writing purpose, they require a N12 font size vision. Okay, so we'll move on to optical devices. So these are the optical devices for distance. So the first, telescope. Yes, we have a telescope, CTV binocular telescope, Galilean telescope, Keplerian telescope, and autofocus telescopes. We'll see one by one. So first we'll see binocular telescope. So these are the binocular telescope. It's also called as a CTV. The advantages are it has an intermediate distance, wider field of vision, and it has spectacle model. The disadvantages are it has only a 2x magnification and it can't be used for a mobility purpose, and the spatial disorientation will be there. We'll move on to the telescope. We have a handheld and spectacle mounted magnifiers. The advantages are range of magnifications are available from 3x to 10x. It can be viewed for blackboard and signboards, and we can use for variable distances, distance, intermediate, and also for a near. And the disadvantages are laser field of view, handling difficulty, and poor cosmosis. The biopic telescope, there is a miniature telescope mounted toward the top of the glasses. There are fixed, manual, and autofocus types are available, and it has a magnification from 2.2x up to 6x. Now, these are the optical devices available for near. So, off-eye spectacles, dome magnifiers, stand magnifiers, and the assistive devices. Spectacle magnifiers, the advantages are wider field of view, better cosmosis, hand-free, and the wider range of magnification available from 1x to 6x, and it can be used for continuous reading. The disadvantages are closer working distance, postural difficulty, magnification, it's not available more than 6x. That means it's not available more than 24 diopters, and it needs to be removed to look at far distance. And handheld magnifiers, the advantages are better working distance, self-illumination, portable, and mostly affordable. The disadvantages are it can be used only for spotting tasks, limited range of magnifications available, and the limited field of view. And it can't be, it will be difficult to use the handheld magnifiers, patients with tremors. In the stand magnifiers, wider range of magnifications available from 2x to 14x, self-illumination also possible. The main advantages it can use for reading also, especially the cutaway magnifiers. And the disadvantages are again a closer working distance, postural difficulty, and limited field of view. The dome magnifier, so the advantages, better working distance, optimum range of magnification, can be used for continuous reading tasks, especially for a school and college going students. And the disadvantages, it's not useful for a writing task. Packet magnifier, the advantages are portable, wide range of magnifications are available, better working distance, and self-illumination possible. The disadvantages are again limited field of view and only for the spotting purpose we can use. And we have a Fresnel sheet magnifiers. The advantages are wider field of view, better working distance, and comfortable posture. The disadvantages, the limited magnification. So if the magnification, if we increase in Fresnel sheet, the quality of vision will decrease. So these are the options of LVD for distance, for educational and occupational purpose. For example, blackboard viewing and PowerPoint presentation, we can always go ahead with prescribing telescopes. And recreational for watching TV to recognize people's faces, you can prescribe CTV binocular telescopes. For a near, for a continuous reading purpose, newspaper and official documents, school books, everything, spectacle magnifier, stand magnifier, and the dome magnifier for a spotting purpose. To see receipt, bills, challans, you can use a handle magnifier and packet magnifier. To writing exams, again a spectacle magnifier and the assistive devices. So points to remember when we prescribe low vision aids for myopia, always go ahead with prescribing telescope unaided and always use a Keplerian telescope. That's a handheld monocular telescope, and trial to be done in the better eye, and focusing and tracking need to be reassured. And off-field glasses are available up to 10 prisms, up to 10 diopter. The prisms are incorporated. If there is any significant cylindrical power, to separate reading glasses. If the significant cylindrical power means it's more than 1.5 diopter cylinder, and myopia, always leave them as unaided. 1 year. So I would like to end my presentation with this quote. If you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving. Thank you. And I would like to thank the organization, TNOU, and pediatric ophthalmologist, Dr. Kavita Kalivani, who gave me this opportunity to present. Thank you, one and all.
Thank you, Ms. Dara, for the detailed presentation covering all the aspects of optical aids. Next, we will move on to the next topic. Are my slides visible?
Yes, Fatima.
Yes.
Yeah. It's about non-optical low vision aids. As we struggle hard to improve the visual acuity with all these efforts, our job doesn't end here because there are other aspects in vision rehabilitation. Importantly, non-optical aids and accessories, environmental modifications, vocational rehabilitation, which in detail was covered, and motivation part. For all these aspects, we need thorough understanding of the patient. Thorough understanding can be in these areas. First of all, we have to understand how much is the reading need for the patient and the ability, and what are the difficulties in their day-to-day activities, and how about the patient safety, whether they even encounter frequent falls due to visual impairment, such things, and psychological well-beings, and whether they continually participate in community despite vision loss. So for the reading, when we prescribe optical aids, the accessory, the must should be reading stand, because without reading stand, when a child peeps over the optical aid, the posture he adopts is not good, and there will be usually our houses are littered with ceiling light, where there will be a falling of a shadow over the printed documents. So this kind of reading stand with adjustable height will improve the posture as well as the lighting. It is also available in a nice plastic portable model also. And this will be in detail described by next speaker. And we have letter guide, where this simple black and white, this contrast letter guide helps the students to write in straight lines and also improve the handwriting. And the notex is the one to identify the currency. This is made for the older currencies, which we have modified with the help of for this latest after demonetization. For the newer currency, we have come up with 3D printed guide, notex guide, for along with the braille imprints for identification. And we made customized purse for accommodating individual currencies in the particular chambers. Like we have two compartments there, where higher denomination currencies and here lower denomination, the length and width are adjusted to that particular currencies for the patients to be benefited. And here is another non-optical aid, very useful for a threading needle. And here we have a metallic device, small, and easily it can be inserted into the hole of the needle. And once it is easily threaded, we can thread this needle. We can thread the device and pull it, that's all. And the needle will be threaded. And here comes the typoscope. As we know, it gives a contrast and it can be useful to put signature in place and even to read individual lines in a textbook. And there are many other devices. For mobility, we have cane, smart cane, and guide dogs, not particularly in our country, maybe in Western countries, most commonly used. And cane is available in portable model, easy to carry, and it can be easily unfolded. And the red sticker here says the patient is visually impaired. If there are double red stickers, it implies patient is also having hearing impairment. Cane training is not just prescribing cane. It needs some training. Let me play this video.
Okay, first குச்சியை நல்லா விரிச்சு பிடிச்சுக்கோங்க. பிடிச்சிட்டு அதை கீழே விரிச்சு வச்சுக்கோங்க. அதை நெஞ்சுக்கு நேரா இருக்க மாதிரி நிமித்தி பிடிச்சிட்டு தளர்த்தி வச்சுக்கோங்க. முன்னாடி தரையில தட்டி தட்டி பாருங்க. கீழே இது மேடு பள்ளம் இருந்தா உங்களுக்கு சவுண்ட் கேட்கும், அது வித்தியாசம் தெரியும். சரிங்களா? இப்ப நடக்க ஆரம்பிங்க. இப்ப சைட்ல ஏதாவது பொருள் இருந்தா அதுல சைட்ல இடிக்கிறத வச்சு உங்களுக்கு அந்த சவுண்ட் வித்தியாசம் தெரியும். அதை வச்சு தெரிஞ்சுக்கலாம் நீங்க. இப்போ தரத்தளத்தை சமமா இருக்கும்போது நடக்கும்போது உங்களுக்கு ஒரே மாதிரிதான் இருக்கும். ஏதாவது பல்ல ஏதாவது வந்ததுன்னா கீழே குச்சி போகும், அதை வச்சு அதுக்கு முன்னாடி பல்ல இருக்குன்னு தெரிஞ்சுக்கலாம். ஏதாவது மேடு இருந்ததுன்னா அதை இடிச்சிட்டு நிக்கும். இப்போ படியில இறங்கும் போது குச்சியை நல்லா பென்சிலை பிடிக்கிற மாதிரி பிடிச்சுக்கோங்க. பிடிச்சிட்டு ஒவ்வொரு படியா இறங்கி மெதுவா ஒவ்வொரு காலா எடுத்து கீழே வைங்க. மெதுவா அப்படியே இறங்குங்க. இப்ப வீட்டு வாசல்ல புல்தரையில நடக்கிறதுக்கும் நார்மல் கார்ல நடக்கிறதுக்கும் உங்களுக்கு வித்தியாசம், அந்த சவுண்ட் வித்தியாசத்தை வச்சு தெரியும். வீட்டுல இருந்து எத்தனை ஸ்டெப்ல ரோடு வருதுங்கிற அந்த நீங்க மனக்கணக்குல வச்சுக்கணும். இப்ப 45 அடினா 45 அடியில தெரு வந்து தெரிஞ்சிடும்.
Okay. Thanks to Ms. Aarti, our staff, who took this nice illustrative video. And we have a smart cane where a device is attached to the head of the cane. This device helps to understand the obstacle above the knee level and also from the overhanging obstacles, which is more common in our setup. So it has two ranges. Where one can set like long range mode and short range mode. If one wants to walk in a free passage fastly, they can set 3 meters range mode. And when they want to traverse through a crowded place, one can set short range so that the obstacle in short distance will be conveyed. And this is the charger coming with the smart cane, and the head can be charged. And the feedback of this cane will be in the form of vibration. It can be set according to the patient's convenience, like single vibration, 2 or repeating vibrations. Coming to the next important area, lighting. Persons with visual impairment needs 3 times as much light in general to do the same task as a person with normal vision. Lights which do not emit the ultraviolet or blue air spectrum light can make a significant difference for those persons with low vision by reducing photo stress and discomfort. Patients with macular degeneration benefit from strong natural light, while those of retinitis pigmentosa benefits from task at hand. And there are wide range of tinted glasses. Usually we prescribe by giving trial to them, and whichever patient feels comfortable, we will prescribe. But more commonly, the patients having cone dystrophy or albinism with photophobia, they prefer dark or red tinted glasses. And for color blindness, Enchroma has a glass which blocks the problematic spectrum of the problematic wavelength spectrum, that is red-green overlapping wavelength 540 to 580 nanometer, so that the appreciation of the colors will be more enhanced. And one has to know about this syndrome because this is characterized by Charles-Bonnet syndrome. It is characterized by recurrent or persistent complex visual hallucination that occurs in visually impaired individuals with intact cognition and no evidence of psychiatric illness. The hallucination may be simple patterns or detailed images of events, people, or places. There is only visual and don't involve hearing things or any other sensation. Patients usually retain insight into the unreal nature of their hallucination. And CBS is often misdiagnosed, and particularly because old age visually impaired patient, when they come up with this sort of symptoms, relatives, attenders within their family can easily label them as psychiatric patient. So we should probe into the details of the symptoms and can diagnose this syndrome so that they will not get unnecessary psychiatric treatment. Rather, they can be helped with this measures, simple measures, changing the lighting conditions, moving eyes from left to right, and staring at the image and blink rapidly, moving around or perform a different task, and getting enough sleep at night. Coming to the environmental modification, this is very important. Though it looks simple, we have to definitely suggest these, share these suggestions to the attenders, whoever son or daughter or parents, because this simple fluorescent stickers over the switches and particularly the gas stoves switches will help them very much in their day-to-day activities. Particularly, they will enhance the safety aspect. More often, they can miss the direction of the switches. And one can we can suggest the chopper board color to be contrast. Like for cutting the dark colored vegetables, they can use a light color background, and for a light color, dark colored chopper board. And always we have to stress the importance of arranging things in an order to all the family members so that the visually impaired will easily go with day-to-day arrangements. And this kind of telephones and this kind of clock in the living room will greatly enhance the patient's day-to-day well-being. And whenever the flooring and the steps are in the same material, same color, definitely it has to be enhanced with the fluorescent margin for the patient's easy mobility. And this is yellow acetate paper, which can be placed over the printed document, and it enhances the contrast sensitivity. Some patients feel good to use it. And this is being so inexpensive, it can be easily suggested to the patient. And there are several different talking products available in the market that can be suggested according to the patient's need. And coming to field effect, though the Fresnel prism, everything is in theory, usually patients will not be comfortable with the Fresnel prism. So we can share the advice regarding their, for example, for a school student, we can write a letter to the teacher. If the patient has right hemianopia, the patient can be seated somewhere here, so that his field, good seeing field will be covering the all other classmates and the teacher, rather than being seated somewhere here. So, and also the office setup can be suggested based upon the patient's field effect. And for field effect patients, we have to make the patient realize their field effect by providing them test and exercise. If we ask them to pick up a particular card, they will easily miss that particular card that come in the field effect. So we have to first make them understand the area of their field effect, and then train them to scan the things in order and not to miss a single one, so that they will make it as a habit in their daily routine. Even while traversing the road, they have to use their head movement and scan the areas that cover up their field effect areas. And vocational rehabilitation was in detail covered. So we will, and finally, how Ms. Dara concluded, the motivation is very important. Always knowledge is the first key, and practice is very, very important. Along with that, positive attitude and motivation. We have to, we all have to try to give all these aspects also along with our low vision aid, so that we can make our patients' vision and life colorful. Thank you for listening to this talk. We will move on to our final speaker. Yeah, Yelango sir, do you like to tell something? Okay, we will move on to Ms. Janani. She's the She's an optometrist, completed her Bachelor of Optometry in RIO, Madras Medical College. She is working in Aravind Hospital, Madurai, and has an experience of 2 years in pediatric and strabismus department and vision therapy, especially in anti-amblyopia therapy and pediatric low vision care. Over to you, Ms. Dharani. Sorry, Janani.
Thank you, ma'am. And happy evening to everyone. So my talk about is electronic aids and smart vision glass. Ma'am, my screen is audible to all, ma'am?
Yeah, yeah, you are audible.
And as you all know that traditionally we are prescribing like optical and non-optical aid. In addition to that, most commonly used electronic aids are CCTV like Ruby as well as mouse model CCTV. The patient will use their like reading material under the camera so that they can get like enlarged image with a higher magnification with the excellent contrast so that they can look through that monitor or TV screen. Even they can use this CCTV like with a comfortable poster, and it will give like wider field of view so that they can read for longer time as well as they can use for writing purpose without any changing in that working poster. And most commonly used video packet magnifier so that they can, it is very portable to them. So it can achieve like a 15x magnification at maximum. If they want to read any specified text or anything else, they want to capture, and they can increase their magnification up to 15x. If they want to change that background, like white with black letters or black background with white letter in that video packet magnifier. Along with that, if visually impaired patient want to access their computer with the help of several software is also available here. In Aravind Hospital, we are commonly using like NVDA. In NVDA is like a open source software when compared to JAWS. In NVDA, the regional languages, like several languages is available there. And compared to JAWS, in JAWS, English language is only available. In our hospital, we are giving like 60 hours certificate course, like online as well as offline basis. Other than this, there are several technologies there, like window eyes and scan reader, as well as voiceover is also there. If the visually impaired patient, if they want to read any reading material, there is a Dignify. If in Dignify, the patient want to keep their mobile phone on that hard platform. So they want to install like a Dignify app in their phone. They want to keep their reading material here. So in reading material, the camera will capture the reading material. If they want to attach, if they want to connect with the Bluetooth, like for getting like audio. If they want to read line by line, they can also connect with the keyboard also. In keyboard, they can access like an arrow mark. So they can, it will be very helpful for them to read line by line in the Dignify. But what is the disadvantage here is it is very difficult for them to access like regional language. It is only supportable for English language. And it is very difficult for them to recognize while reading material, like mathematical expression, any graphical presentation, and picture presentation. And there is another reading software like YouRead. In YouRead, the sensor will capture that reading material. In the reading material, the patient can access to regional language, like they can change like A, B, C, the option will be there. According to that, if they want to get an audio feedback through Tamil or Hindi, whatever else, they can select the option from that button. If they want to speed up their audio, they can change their speed up button will be also there. If they want to increase or decrease the volume, the button that. Next is like Orbit Reader. In Orbit Reader, the patient, if they want to read any books or anything else, they want to store in that SD card like PDF. So in the PDF, automatically changes into Braille form so that the patient want to read line by line through that Orbit Reader. here is the button so that the patient can, if they want to edit or enter anything in that PDF, so that they can change through the Braille language. If they want to connect with the computer or mobile devices, the Braille will help them to access in the computer as well as mobile device. If they want to read any email or anything else, it's very helpful for them in the Orbit reader. And next is like artificial intelligence. In artificial intelligence is E-side. In E-side, the visual impaired patient, like they need like residual vision for seeing like higher quality video in that E-side in front of each eye. The cost will come around like 8 lakhs. It is not suitable for mobility purpose. In RCAM, it is almost similar to smart vision glass, but here is the cost will come around like 3 to 4 lakhs. In RCAM, only that English and Hindi language will be supportable, and it will capture that image in front of the eye so that it will give like audio feedback to you. Next is your smart vision glass. In our hospital, we are suggesting smart vision glass for the patient. In smart vision glass, there inside temporal, there will be an artificial intelligence is there. Here is a camera, and there will be a Braille type button will be here. So the smart vision glass is mainly used to recognize object in front of smart vision glass. It will be useful for read text, and if they want to recognize face or they want to store their face is also available, and it will also be used for navigation purpose. So who can use this smart vision glasses? No light perception to if it is less than 6/60. If their visual acuity is less than 20 degree, if they're having any inferior or specified field defect, they can also use the smart vision glass. For using the smart vision glass, the patient will have like a good cognition. Then only they will able to use the smart vision glass. What is the advantage in the smart vision glass? When compared to RCAM, it is very affordable, and regional language is supportable when compared to RCAM. A handwritten under a signboard, it will be easy for them to recognize through audio feedback. And if they want to read any Braille type handwritten Braille type material, it is very easy for them to use like smart vision glass. And if the patient want to store the patient face and their expression as well as age, everything is available in that smart vision glass. While walking, the patient wants to know the obstacle or any glass door in front of their eye. The smart vision glass will give them like audio feedback to them, and it will also help them to identify like color in front of their textbook or whatever the material will have in front of their eye. And this is an video will show you that a visually impaired person will. Button. here so that they can store their faces, as well as they can, if they want to increase their audio, like there will be a last button, value button, so that they can increase or decrease their audio value also there. And in future enhancement in the smart vision glasses, the camera is placed in the temporal side. In future advancement in smart vision glass generation third, the camera will be exactly on the center. It will give like 120-degree field of vision, and it's very easy for them to assess like low-lying obstacles, and it will help them for currency identification. The page, like the visually impaired school-going children, they can easily access to books, features, and it will help them for more selection from your white canons. And thank you all.
Thank you, Ms. Janani, for that wonderful presentation. And it is good to know that smart vision is coming. Smart vision glass is coming with another generation of having a central camera. It will improve the cosmosis more higher. Any other comments from panel?
I think most of these low vision aids are now replaced with the mobile camera. I mean, mobile phone. So you can take just a snapshot, you can enlarge that. And much of these books that are needed can also be used as a readers also in the mobile phone. All these optical aids, the magnifiers that we were prescribing some 10 years back, I think the mobile phone has replaced all those things. As far as the distant vision is concerned, the telescopes, whether it is Galilean or Keplerian, the autofocus telescopes definitely has a role, but still it is quite expensive, comes to around 30,000 rupees. And currently, I think the smart glasses will definitely help these patients with visually impaired. But all the cost has to come down, unless it may not be affordable for the patients actually. When the cost of the IOL, the GST has been reduced from 12% to 5% for our IOLs. I think for visually impaired, this is very, very important. For the low vision aids, the GST has to come down and it has to be made more affordable. Those are my comments. Thank you.
Yes, sir, that is very true. The cost of LVA device should be low, but it is other way actually in reality. And wherein the funds from, in our hospital, I like to remember Manavar Devadas sir's Mahima Fund had helped a lot of patients. But it should be universally at a low price. Government should do something about it. Since it will not move in the market, very less necessity, the market price is not coming down. That is a sad reality. Any others?
Any other questions, clarification? Meenakshi?
No, sir, they are covered very well. And
Yeah,
the thing
really
is,
true.
even non-optical aids play a big role. And as rightly pointed out by Dr. Ilango, a lot of things are now available on the smartphone itself. And but the thing is, we have to tell them that so many things we come to know only after we attended some of the sessions, that so much is smartphone.
Yeah, that's
That is
correct.
also
Yeah.
there.
Yeah.
Who know that it is there, we can't tell them also that.
Okay. Thank you. So more than 2 hours. Really, it's a wonderful session. We learned a lot because we don't know much about the all these low vision aids and other things. Thank you. I request Dr. Atik to propose what of things.
Thank you, sir.
Sriram, our secretary is there.
Yes, sir, I logged in, sir.
No, okay, yeah.
I think Adi can carry on, sir. No problem. I'm actually driving, so.
Okay, yeah. Yes.
Thank you, sir. First, heartfelt thanks for this wonderful webinar. Was a real thought-provoking and a big eye-opener. So much has come into low vision aids, and I sincerely feel that every optometrist in every hospital, every eye clinic, every institution should watch this webinar. I think this has kind of been not very explored territory. And so lots and lots are there, and some of the videos shown by many speakers were amazing. Sincere thanks to the patients who shared those videos, because they were really enlightening. And every patient is totally different, is what I personally understood. There is no a single thumb rule which can be taken and used for every patient. Lots of learning. Thank you very much. Heartfelt thanks to Ramakrishnan sir for having thought of this concept to have a low vision aid webinar. Thanks to Fatima madam for having organized the session and wonderfully moderated it. Thanks to our panelists, Ilango sir, for the wonderful inputs in between the talks. Thank you, Meenakshi madam, Deepa madam, and Dr. Neelam for the wonderful inputs. Thanks to our speakers, Dr. Sabyasachi, Tanuja madam, Dr. Sahithya, Sandra madam, Ms. Tarakeswari, Fatima madam, and Ms. Janani, and to Dr. Suraj Singh for the wonderful talk. Last but not the least, thanks to Aurolab for having come up and sponsored this session. Thank you so much. Until next time, thank you.
And also thank Numerotech, Sai and Manjula for the constant support. So, yeah, thank you. Thank you all. Thank you. See you.
Thank you, sir.
Next
Thank you
time
so much.
we will see you all in 16th with an exciting guest lecture by David Shank.
Yes, sir.
Okay.
Sure,
Thank
sir,
you.
sure, sir. Thank you, sir.
And thank you.